We go on with acute hepatitis B. Acute hepatitis B is transmitted by parenteral route. So it may be transmitted by blood or blood products like saliva or any semen, another blood, another secretion of body fluid. But the risk is most with sharing some instruments like razors, toothbrushes, or something like this, which are exposed to the blood of the infected subject, because of this infectious route, it is more common in the regions that in the same house there are too many people living together. So if hepatitis B is present in one, it will be transmitted to others in the long run. But I'm going to say that it is not transmitted in work environment. It is not transmitted by something like spoon, fork. So it is only transmitted by blood or body fluids. So if you have a patient with hepatitis B carrying state, you do not need to be too worried, because in work environment it is not transmitted, very rarely transmitted. And acute hepatitis B is anicteric in the majority of the cases, so jaundice is not present. The hepatitis B virus can be transmitted in two ways. One is vertical and the other horizontal. Vertical means that it is transmitted from mother to baby. The risk is the highest in this setting. So if the mother is not screened for hepatitis B and the newborn is not vaccinated and administered immune globulin, if it is necessary, then the chronicity rate is 100%. It was very common some, say, 30 years ago, but in recent times, all the pregnant ladies are screened for hepatitis B, and if they are found positive, then the baby is vaccinated at the birth. And if the pregnant lady has some features that suggest that this virus would be transmitted despite vaccination, so there is a very high viral load, then at the same time, hepatitis B hyperimmunoglobulin is also administered to baby. So with these measures, the vertical transmission was controlled to a great extent. It does not happen frequently, very, very infrequently. When it would happen, if the pregnant lady has not come into the attention of the healthcare, and if she gives birth in a house, then it may still happen, but it's very rare. Horizontal means that it is transmitted from somebody to the other in house environment. The risk of chronicity is less in comparison to vertical. Actually, there is a correlation between the chronicity and the age. If the infection is transmitted in newborn, the chronicity rate is the highest. In children, it is moderately high, but in adults, it is very, very low. So if an adult is having an acute hepatitis B infection, the chronicity rate is very, very low. And there is another condition, which is a very fearful condition, which is called as acute liver failure. Acute liver failure happens in less than 1% of patients with acute hepatitis B. But if it happens, it may require immediate liver transplantation. Because of this, we assume that most of the cases of acute hepatitis B are benign, but we should take into account that there may be a risk of fulminant hepatitis. Because of this, we are following these patients closely. What are the markers of disease? Because you may be asked by your friends or relatives about this if they know that you are a medical student. If HBsAg is present in circulation, it indicates that there is an carrier state. But in this active carrier state, the disease may be either active or inactive. If liver parameters are not suggesting an inflammation, it means that this person is carrying HBsAg in active carrier state, but there is no activity in the liver. So this is called as inactive carrier state. I mean, HBsAg positive, HBV DNA is lower than this, ALT and AST normal, then inactive carrier state. If anti-HBs and anti-HBC are present together, it indicates that the patient has had the virus in the past, has been exposed to the virus in the past, but immunity developed. So these subjects are immune against hepatitis B infection. If only anti-HBs is present, then it means that immunity was induced by vaccine. But these subjects are also completely protecting against hepatitis B infection. HBeAg presence indicates that this is a wild type of infection. There are two types of infection: wild type with HBeAg and mutant type with anti-HBe positivity. Actually, I am telling this in order to let you know about something for hepatitis B, but this is beyond the scope of your examinations. HBV DNA over 2,000 unit per mil is indicating that the viral load is high, so this patient would require treatment. For example, somebody would ask you, oh, this is my HBV DNA, what do you think about this? And you would say that if it is over 2,000, you may require treatment. Anti-delta presence means that there is chronic delta hepatitis. We go on with a patient. The patient presented with abdominal pain. It started recently. And in physical examination, there is hepatomegaly and splenomegaly. HBsAg positive, E negative. Serum transaminases, these are called as serum transaminases, are elevated. HBV DNA is very high, and alpha-fetoprotein, that's an marker for hepatocellular carcinoma, is elevated as well. And you see that a very large mass here. In the previous lectures, I told you that liver cirrhosis is a disease difficult to diagnose, and it may be asymptomatic for years. For example, in this patient, hepatitis B happened in the past. It ran into chronicity, cirrhosis developed, hepatocellular carcinoma started, and it came to this level, a very large one, and the patient was diagnosed at this time. So it means that this patient has had hepatitis B at least 10 years or 20 years ago. So we should try to prevent the occurrence of such a picture, and we should screen for anybody living in our country for HBsAg. If it is positive, then we should do another tests to decide whether this patient requires treatment or not. What is the prognosis in hepatitis B? If the patient is not treated, and if he or she is requiring treatment and not treated, in this case, in up to 20%, in 5 years, cirrhosis may develop. But keep in mind that all HBsAg positives do not require treatment. Some of these require treatment, and this is decided by the hepatologist whether this subject is requiring treatment or not. But if he or she is requiring and not treated, then there is a very high risk of development of cirrhosis. And in compensated cirrhosis, 15% of the compensated cirrhosis patients and more than 60% of the decompensated cirrhotic patients with hepatitis B are dying of their disease in the following 5 years. You see there is a very complex life cycle of hepatitis B virus, but we believe that in the following years, we are going to have very effective means to treat hepatitis B infection. At the present time, our drugs are stopping the replication of the virus, but we cannot cure the disease. Why? Because hepatitis B virus is integrating into the hepatocyte genomic material. And this is the genomic material of hepatitis B, closely covalent circular DNA. And it is very difficult to get rid of this structure once it is implemented into the host hepatocyte. But nowadays, there are some treatments that are developed that I think in the near future, we are going to cure the disease. Hepatitis C is less common. And in Turkey, we believe that the prevalence is less than 0.5%. Previously, this was a very frightening disease, but now there are very, very effective treatments. And because of this, it dropped from attention. But there are still patients with hepatitis C. They are undiagnosed. And as it is in hepatitis B, if hepatitis C is going undiagnosed, it will result with cirrhosis and hepatocellular carcinoma. So we should screen for markers. What marker? Anti-HCV. If somebody is anti-HCV positive, we look for HCV RNA, the genetic material of hepatitis C virus. If this is positive, but this is negative, so it is happening in at least 1/3 of the patients with anti-HCV positivity, it means that the patient has been exposed to hepatitis C virus in the past, but the disease results with resolution. If both are positive, it indicates active infection. This subject is requiring treatment. This does not require treatment. So alone, anti-HCV positivity does not indicate that this patient is requiring treatment. The patients who are HCV RNA positive are requiring treatment. And if this one negative and HCV RNA positive, it indicates acute infection, early phase of acute infection. Acute infection progresses to chronicity in at least 50% of the subjects if left untreated. You see, there's a striking contrast between hepatitis B and hepatitis C, because in hepatitis B, chronicity rate is very low, even absent in adults. But in hepatitis C, it is more than 50%. This is because hepatitis C is once the subject is exposed to hepatitis B virus, hepatitis C virus, it is reaching the liver in a very short time. And in this very short time, immune system cannot overcome the virus. So it causes chronic disease. And if 30% of the subjects, chronic infection progresses to cirrhosis in case it is untreated. And the risk of hepatocellular carcinoma is very high. In addition to liver conditions, chronic hepatitis C infection may cause some extrahepatic conditions like immune-mediated diseases. But the cure rate with the development of new drugs is up to 100%. And you see that we first started some 30 years ago with 6% success rate. Now the success rate reached 100%. At that time, the drugs were having very significant adverse effects, and today's drugs do not have any adverse effects. So this is actually success story. And now hepatitis C, if you diagnose it, treatment is 100% effective. Now we go on with fatty liver. Finally, fatty liver means that there is more than 5% of fat in liver. But for the diagnosis radiologically, the liver fat content should be over 30%. So between 5 and 30%, it is very difficult to say that there is fatty liver by any means. And you see, this is a patient with fatty liver, enlarged and yellowish discoloration. What are the symptoms of fatty liver? Sometimes these patients are totally asymptomatic. This is happening in half of the patients. In the other half, there may be an fullness in right hypochondrium, sometimes radiating to the back, especially when the patient is in sitting position, for example, while driving. In some patients, there may be dyspepsia, but all these symptoms are present in less than half, even less than 1/3 of the patients. In physical examination, the most frequent finding is hepatomegaly, and it may be painful. But hepatomegaly, again, is present in less than half of the patients. In half of the patients, liver may not be felt below arcus costarum. The fatty liver disease may be either alcohol or it may not be due to alcohol. In non-alcoholic type, there is mostly obesity and sometimes diabetes mellitus or insulin resistance. We are differentiating two types of fatty liver. One is benign one. There is fat in the liver, but no inflammation. In these subjects, the course of the disease is benign. But if there is inflammation, we call it as non-alcoholic steatohepatitis. Steatohepatitis means that in addition to fat, there is inflammation. This is dangerous because it causes progressive fibrosis and cirrhosis, even hepatocellular carcinoma may develop. But this process is also a dynamic one. A patient may start as non-alcoholic fatty liver and will progress to non-alcoholic steatohepatitis. In general population, in our society, we believe that it is present in more than 15% of the subjects. If the patient is also taking alcohol, the fatty liver reaches 50%. And if the subject is both obese and alcohol taking, then the prevalence is up to 100%. In obese patients over 30, but without alcohol intake, it is 70%, still very high. NASH, non-alcoholic steatohepatitis, the dangerous one. In general population, it is 3%. In obese subject, it is up to 20%. So it means that at least 1 in 5 of obese patients are under the risk of liver cirrhosis. I showed you this cartoon in a previous lecture, I think in cirrhosis lecture. And free fatty acids, when they come to liver, they are going into beta oxidation in mitochondria of hepatocytes. You see, hepatocyte is very rich of mitochondria, up to 50 mitochondria per hepatocyte. And this beta oxidation is providing body temperature. But when FFA is out of metabolizing capacity of the hepatocyte, inevitably it is accumulated in liver, and fatty liver develops in this way. In hepatocyte, it is accumulated as triglyceride. And when the triglyceride accumulation in hepatocyte is over the capacity that hepatocyte would keep, then it is going into microsomal oxidation. And in this microsomal oxidation, some chemicals would be in hepatocyte as well as in circulation, and they would cause some damage to liver. These are called as free radicals. Free radicals are some naturally occurring products, but their level in body is very low. If they are elevated, they would cause tissue damage. And if triglycerides are going into microsomal oxidation, free radicals are increasing and they are damaging the liver. And some free fatty acids are also secreted in the circulation, is in the form of very low density lipoprotein to provide energy to muscle when the subject is in fasting state. Actually, our body is having a very effective protection against fasting. For example, if the subject does not have enough food to eat, then in this case, hepatocyte would provide the energy requirement with this very low density lipoprotein. These are energy compounds. But for obesity, there is no protection mechanism. So if somebody is overeating, there is no protection mechanism. So at the end, the patient will end up with serious diseases. In this process, this space, there are some other cytokines having some roles, like leptin, transforming growth factor beta, TNF-alpha, and nitric oxide. These are produced by Kupffer cells. Kupffer cells is the fifth category of liver. I have mentioned that in liver, most of the cells are hepatocytes, but in addition to hepatocytes, there are bile duct epithelial cell, endothelial cell, and stellate cell. And the fifth group of cells are Kupffer cells. Kupffer cells are in the vicinity of endothelium. These are local macrophages. And in fatty liver, there is a leaking intestine. So some substances like LPS, lipopolysaccharide, this is a product of some bacteria, are permeated into the portal vein and coming into liver. This is not something physiologic. It happens in some leak from intestine, and fatty liver is one of the causes for this. And LPS would activate local macrophages and NF-kappa B, and these cytokines are produced. And these cytokines, in addition to the production of excessive free radicals, would cause fibrosis in this space. And so in this process, in the long run, cirrhosis develops. Ultrasonography is a very effective method to diagnose fatty liver. And we differentiate 3 stages. And if it is in the 3rd stage, it means that 90% of the liver is composed of fatty accumulation. We reviewed some 94 patients with biopsy-proven non-alcoholic fatty liver diseases. And interestingly, in some patients in normal weight, below BMI, below 25, there may still be steatohepatitis. This is 16%. Interestingly, what we have found that in these patients, there is a very high rate of ingestion of animal products. When we stopped animal products in most of these patients, fatty liver went into resolution. And you see that in general population, this is general population, and this is population with fatty liver. In fatty liver population, the overweight and obese patients are predominating. And these general population, it is significantly less. So if you are overweight, you are under the risk of fatty liver. If you are obese, you are under the risk of fatty liver very, very significantly. And in these patients, 1/3 of the subjects are having type 2 diabetes mellitus. And in addition, 43% are having insulin resistance. So insulin resistance and diabetes mellitus is very high in obese subjects. Because of this, these are very frequent in fatty liver as well. Hypertriglyceridemia is not very common, around 1/3. And hypercholesterolemia is in 2/3. And both in 23%. So in a subject with significant fatty liver disease, serum triglyceride level as well as cholesterol level may be in normal range. If these are in normal range, it does not mean that the patient would not develop fatty liver disease. As a result, in our society, the people who are having cirrhosis or they are under the risk of cirrhosis, the risk is fatty liver in at least 1/3 of the subjects. And in at least 85% of the subjects, this is a preventable disease by treating obesity. And we are preferring lifestyle changes rather than like stomach balloon administration, obesity surgery. We want the patient to lose weight by some dietary changes and lifestyle changes. But despite this, most of these obese subjects cannot control their food take, and they eventually are going into bariatric surgery, but we do not know about the long-term results of this type of surgery. So the best way is to keep our population in normal weight. Then we will prevent at least 1/3 of the future cirrhosis. Thank you very much.